Okay, welcome everybody. Welcome to another SPR webinar. We are very happy to have you all here. Today we have a wonderful presentation by a wonderful person. She is Alemka Tomicic. She has a great presentation for us today. Before I let her start with her presentation, I would like to let you all know that the webinar is being recorded and that the recording will be available afterwards. You may leave your questions in the chat box, which we will be taking at the end of the talk. And you may also raise your hands at the end of the presentation if you want to speak with Alemka directly. And having that said, let me tell you a little bit about her. She is a PhD. She is an associate professor at the Faculty of Psychology at the Universidad de Diego Portales de Chile, and is the director of the Undergraduate School of Psychology of the same faculty. She is a researcher at the Center of Clinical Psychology and Psychotherapy Studies, and an associate researcher at the Millennium Institute for Research in Depression and Personality. She has been dedicated to researching psychotherapeutic interaction and subjective experience in psychotherapy, as well as illness processes and mental health. She is currently leading a research project for the development of guidelines for the conduct of sensitive and competent psychotherapy in the context of sexual and gender diversity. So we are very happy to be able to count with your time and your predisposition to give us a little bit of your knowledge today. So Alemka, having that said, thank you very much for being here, and I'll be listening very attentively to your talk.
Hi, sorry, my Spanglish. Hello, everybody. I am very happy to be here. Thank you, Juan, for introducing me. I am very happy also to look at a lot of known faces, and I'm very grateful for this invitation of the SPR to show and share with you what has been a line of research that not only has been developed by me, also by a very great team and big team. So I'm going to share first the presentation. I hope this will function. This is okay?
Perfect, Alemka, we see it great.
Okay. Thank you. Well, in this presentation, by means the revision of 3 studies, I will try to present some learnings for a sensitive and culturally competent approach for researching psychotherapy with LGBT people. With this purpose, I will present first a brief general background, specifically the generic model of psychotherapy as a framework that we have been using. Then I will present 3 studies that we have been conducting with different methodologies. And for each study, I will present a brief background, some aspect of the methodology, and some select results and brief conclusions. And finally, taking into account these studies, I will share with you some learnings for a sensitive and culturally competent approach. So let us start with this general background. First of all, the results of several studies that we have been developed in the last few years suggest that these 4 topics demand the generation of more knowledge. First, mental health disparities and barriers to access to psychotherapeutic treatment for LGBT people. Second, LGBT people's apprehensions towards psychotherapy. In the third place, internalization of sexual stigma in LGBT people that is related with more mental health problems, resistance to attend psychotherapy, and its impact on the formation of therapeutic alliance. And finally, therapist attitude and prejudice towards LGBT people and their impact on the helping relationship and the therapeutic alliance. As some of you may know, the generic model of psychotherapy is a trans-theoretical framework that integrates empirical findings from studies related to the therapeutic process and its outcomes. The generic model is not itself a theory of clinical practice, but rather a conceptual model that guides process outcome research in psychotherapy. And for us, the most important is that it offers a framework for organizing the production of knowledge about the relationship between aspects that determine and constitute the psychotherapeutic process, as well as the consequence that it has on patients, their families and relatives, and also their social environment. So for these reasons, we thought that the generic model of psychotherapy would work as a guide to organize the study of psychotherapy with LGBT patients or LGBT patients. So let me say something about these three components applied to psychotherapy with LGBT patients. With respect to determinants of psychotherapy with persons belonging to sexual and gender diversity, particularly relevant from the point of view of research and practice are these four elements. First, the changes tending to a progressive acceptance and the pathologization of gay, lesbian, bisexual, genderqueer, and transgender people. Second, the persistence and emergence of new forms of discrimination and victimization of LGBT people. In the third place, the existence of mental health disparities and barriers to access to psychological and psychotherapeutic care for LGBT patients. And finally, the identity and professional training of therapists. Regarding constituents of psychotherapy, studies show the particularly relevant to the experience and behavior of each participant during the psychotherapeutic process. These three things, the effects of psychotherapy's prejudice and microaggressions in the helping relationship with LGBT patients. Second, the development of affirmative psychotherapeutic practice. This has a lot of research. And in the third place, therapist self-disclosures in the therapeutic work with LGBT patients. And finally, regarding consequences, there are few studies on the clinical outcome of psychotherapy with LGBT patients, and above all, about the consequences it has on the life trajectory of its participants. The research and formulation that we have been able to find in this regard refer to these three aspects. In the first place, patient satisfaction with psychotherapy. Second, the consequences for this patient of positive and negative intervention in psychotherapy. And finally, the construction of a positive identity and a meaningful life project. So, well, now, as I told you before, I will present broadly three studies that are oriented by this framework I just presented. The first has a correlational approach and look for to determine effects of the internalization of sexual stigma on mental health. Some general background for this study in specific. There is a profuse evidence of how systematic exposure of homo, lesbo, bi, transphobic victimization and discrimination causes LGBT people to have negative mental health indicators, in comparison with their heterosexual and cisgender peers. And for this reason, there is an increasing need and demand for knowledge about the social and cultural determinant of mental health in LGBT population, which should lead to the development of culturally competent psychological and psychotherapeutic interventions. Therefore, in this case, the aim of this study was to determine the association between internalization of sexual stigma in LGBT+ people and subjective discomfort and depressive and anxious symptoms. Before go directly in this study, I think it's important to talk about briefly about internalization of sexual stigma. The internalization of stigma consists in the adoption of stigmatization, prejudice, and discrimination by individuals belonging to sexual minority as part of their value system. This internalization can be manifest both in an outward and inward direction. Outward manifestations are in general negative global attitudes and language against LGBT people. Meanwhile, inward manifestations are mainly distress around the revelation of one sexual oriented to other LGBT individual, discomfort regarding same-sex sexual activity, internal conflicts, reduced self-esteem, self-loathing, and self-inflicted violence. So let me say something about the method. We administered a survey to 169 cisgender people self-identify as non-heterosexual. And in this survey, we include the administration of the internalized homonegativity inventory, in which internalized sexual stigma is defined as the constellation of negative attitude that LGBT people possess toward homosexuality in general and toward homosexuality features in themselves. And this broad definition is composed, as you can see, by 3 factors. The first one, personal homonegativity measure, has to do with negative emotion that people have about their own homosexuality, for example, shame, depression, embarrassment, and also negative attitude toward their own homosexuality. For example, resenting their sexual orientation or wanting to control their same-sex attractions. Second, affirmation measures the extent to which people feel that their homosexuality is an important and positive part of them, and that being homosexual is normal and fulfilling. And in a third place, morality of homosexuality measures negative attitudes regarding the moral implication of same-sex behaviors and attraction. These are the results in terms of mental health indicator of this sample. As you can see in the slide, 64% of the participants had thought about committing suicide, and 24 had attempted to do so at least once. And considering the last 6 months, 28% of the participants had thought about taking their own life, and around 5% had attempted to do so. And here, what I want to highlight is that these results are relatively high in comparison to those reported in a national survey in Chile, for the general population, in which around 11% of persons have seriously thought on committed suicide. This is a report of 2019, sorry. And as we expected, the results showed an association between internalized sexual stigma and suicidality. That is to say, LGBT people who presented high levels of internalized sexual stigma were more likely to present suicidal ideation and suicide attempts. And this pattern of association was observed in the three components of internalized sexual stigma: morality of homosexuality, affirmation, and personal homonegativity. And a third result I want to show here is these results show that LGBT people who present, again, high level of internalized sexual stigma presented higher levels of subjective distress and more presence of depressive symptomatology. What is interesting in this result is that this association was not observed in the case of the component of morality of homosexuality. This component can be thought as more distal in terms of identity, in comparison with personal homonegativity that can be thought as a more proximal one, and maybe this is the explanation in these different results. So for this study that I have presented briefly, some general conclusions. First, internalized sexual stigma in LGBT people is an important predictor of negative mental health outcome, with suicidality being one of its most direct expressions. Second, lack of affirmation of sexual identity and negative attitude towards one's sexual orientation, that is personal homonegativity, are the aspects of internalized sexual stigma that have the most negative effects on the mental health and well-being of LGBT people. And finally, internalized sexual stigma, particularly personal homonegativity, is, in our point of view, highly relevant focus of psychotherapy work and should be prioritized by psychotherapists. The second study has a qualitative and multi-case approach and looked for described psychotherapy with LGBT people from the perspective of patients and therapists. A review of the literature indicates that there are few studies oriented to develop of an integrative understanding to account for characteristics of psychotherapy and the process of change with patient belongings to sexual and gender diversity. Therefore, following the rationale of generic model of psychotherapy, in this qualitative research, we try to describe specific elements that would be part of a sensitive and competent psychotherapy with a lesbian, gay, and bisexual patient based on the experiences of patient and therapist. For this, we designed a qualitative study with semi-structured interviews with LGBT persons who are or have been at least once in psychotherapy. And also, the study considered interviews with psychotherapists with some experience with LGBT patients. That means which have had at least a patient of sexual and gender diversity. We interviewed 12 therapists and 12 patients, all self-identified as cisgender. A focused analysis based on grounded theory and open coding based on grounded theory too were simultaneously applied. In the case of the focused analysis and following the application of the generic model of psychotherapy as a guiding framework, 3 focus codes were defined: determinant, constituents, and consequences. And on the other hand, open coding was oriented to complete the focus code with emerging concepts and properties. So here you can see the main categories for each focus for the case of the therapist. As you can see, for determinants, for example, are mentioned LGBT mental health training, knowledge necessary for competent treatment, socio-cultural elements related to the therapist and related to LGBT person, and barrier to mental health access. Considering the constituents, appears the idea of the challenge as therapists for the attention of LGBT person, the psychotherapeutic style, the positioning with LGBT patients, the reason they identify for consulting, psychotherapeutic goals and activities in psychotherapies, and regarding consequences are mentioned on the part of the consequence on the part of the therapist and consequence on the part of the patients. So now I will look and make a zoom in this category that is highlighted in red, regarding the question of whether a specialized psychotherapy for sexual and gender diversity is necessary. Some participants point out the lack of training on sexual and gender diversity, so there is a confusion among therapists on how to address these issues in psychotherapy. Likewise, it observed that the beginning of the search for information and understanding of sexual diversities frequently occurs when LGBT patients arrive asking for therapy. And also, in some therapists, the idea that sexual and gender orientation is not a topic appears, in the sense that if sexual identity is not explicit as part of the reason for asking for psychological help, it would not be relevant to be integrated into the psychotherapeutic intervention. On the parts of the patients, also, we develop categories for these 3 focus. Regarding determinants, they mention sociocultural aspect of LGBT, stigma, prejudice, stereotype, social environment context, LGBT people needs of visibility. Regarding constituents, appear some consultation reasons, specific consultation reasons, some elements related to therapists, for example, approach to sexual orientation, features that contribute to the psychotherapeutic process, and features that hinder the psychotherapeutic process, some elements related to process interventions, and also related to bond and therapeutic alliance. And regarding consequences, they mentioned learning about self-validation of being LGBT and self-validation of sexual identity, symptomatological improvements, change in relating to other people, and appreciation of the psychotherapeutic space. Again, I will say something more about this category highlight in red. A question appears regarding talking about sexual orientation and gender identity in psychotherapy. On the one hand, there is a need and a desire to talk and express sexual orientation in psychotherapeutic space due to the fatigue of hiding it, and when a special relationship of trust is established with the therapist. On the other hand, not telling or not talking appears in some cases when the diverse sexual identity itself does not want to be recognized by the patient, also to hide from the therapist his, her fantasies or sexual desire toward person of the same sex, and because of the fear and shame it produced, and also because to the possibility of not being understood or discriminated against. There is also the idea that it's not necessary to tell, since sexual orientation is evident and easily recognizable, or because they recognize the therapist's difficulty in focusing on non-heterosexual orientation as an issue for therapeutic work. Therefore, a factor upon which both groups agree and which is present at different stages of the process has to do with what some participants call a non-issue. This refers to the approach of the patient's sexual identity as a complicated element at time, like the proverbial elephant in the room. Regarding the specifics, patients recognize the lack of training of their therapist regarding the difficulty that they sometimes have in perceiving the patient's sexual orientation and talking about it, perceiving that therapy could be a space that reproduces heteronormativity. On the other hand, the participants experience the dilemma to tell or not to tell, as pointed out by a participant who decides to tell in terms of being able to speak with someone about something that I keep hidden from all the rest of humanity. So a great challenge for therapists seems to be fine-tuning to discern when sexual orientation and gender identity is a non-issue and when needs to be made an issue, and when not transforming the diverse identity into the center of the conversation because it is not an issue. These shifts about what is an issue and what is not are not fixed and refer to the specificity and cultural competence of the therapist. Finally, in this context, the central questions are when, how, and for what purposes to explore and analyze, for example, the internalized sexual stigma or its expression with the patient. The third study has a qualitative and single case approach and look for analyze a psychotherapy process, which main focus was the internalized sexual stigma of a patient. Some general background again. First, the outness process, so-called coming out, could be endless, and maybe one of the things of the end of the process could be feeling proud of who one is, both in front of oneself and in front of the world. As we have seen so far in this presentation, the internalization of sexual stigma could lead to discomfort regarding same-sex sexual activity, internal conflicts, and so on. However, in a review of empirical research on internalized homonegativity, only 2 of the 201 studies identified focused on psychotherapy interventions. What seems to be an effect of an imbalance between research on the psychosocial effects of internalized homonegativity versus a study that emphasized clinical and psychotherapeutic work on clinical expression of it. This single case analysis, therefore, seeks to exemplify a patient's evolution from obsessive ideas and other symptoms that appear to be an expression of internalized sexual stigma to important changes in the construction of a less dissociated and grounded identity of oneself. So before show you the case, it is important to keep in mind the distinction between explicit internalized stigma and explicit internalized stigma. Many of the effects of internalized stigma are quite visible and explicit. Therefore, clinicians can work more directly with them. Nevertheless, the most difficult task for therapists is what some authors have labeled implicit internalized homonegativity. In many cases, individuals are less conscious of homonegativity, which is expressed in subtle ways and that can confuse therapists. So we analyze the case of Fabian, it's not his real name, and we transcribe the therapist's notes, in which included a session-by-session record of the patient's verbatim utterances, summaries of the subject of the sessions, and the therapist's counter-transferential impressions. Fabian is a gay-identified cisgender man in his 30s. He first consults for 3 weeks after coming out with his parents. The patient's main complaint concerned with his obsessive idea of having contracted HIV despite never having had sex at this time. He describes himself as a sociable person, although he did not make many friends in school. And he felt there was always some tension inside him, which made him avoid intimacy and closeness in his relationships. He described his homosexuality as a stain. He agreed to work on the acceptance of his homosexuality so he would be able to live at ease with his sexual orientation. Over the next 10 years, the patient will leave and return 4 more times to psychotherapy. Well, as you can see and reading the slide, in the 4 periods, there is a pattern of explicit manifestation of internalized stigma. In the first period that we named it, because it was the core work, being gay, the expression was being gay as an error and as a misfortune. In the second period, love and falling out of love, the patient imagines or present images of himself as a typically old and lonely gay. In the third period, appears making efforts to be a true man. And in the fourth period, we call the perfect gay, he presents a dream he had in which appears the idea of trying to kill the gay man inside him. Besides, there are 2 main explicit manifestations. First, the obsession with contracting HIV, even though when he has not had sex or risky sex, and maintaining the control in his affective relationships. During these different processes, the therapeutic focus gradually moved towards to a more directly work on the relationship between the experience of homophobia and his internalized stigma. So this is a record from this period in which the patient says, I often wonder what I have done in my life and the effort I have made to be right and do the right thing. And the therapist writes, I show him how the right thing or giving explanations are linked to his own identity. It is not that they might discover he is gay, it is just he must avoid thinking he is a wordless being. Well, and this is the last period in which the theme recorded revolve around internalized homonegativity and work on the positive and gratifying aspect of being gay. There are manifestations of his internalized homonegativity which repeatedly comes back to his mind. However, the patient acknowledged that his problem is not accepting himself as a gay man. This acknowledgement allows him to explore his homonegativity. Slowly, during this last process, Fabian critically examines his social class, the fact that he cannot fit in, and his wish to be the perfect gay, the gay who follows heteronormativity. This led him to recognize the 1,000 phases of his own homonegativity and advance in the construction of a positive and proudly identity as homosexual. Some months before the end of therapy, the patient makes a comment that summarized what this last therapeutic process was like. He said, "I think I took this therapy more seriously. In the others, I came more as an emergency, like this time, but I was able to understand quickly what was behind the symptoms, what was deeper, the procession that goes inside." So, some general conclusions again. First, therapists can educate their patients about a stigmatization process, explaining that this negative internalization of themselves is not an intentional process, but an expectable reaction when living in an oppressive and violent social context, even though this could be not visible for the patient. Second, it should be noted that the worst manifestation of stigmatization tend to appear under stress, which leads people to respond from the perspective of their stigmatized identity. An important psychotherapeutic work is the identification of the patient's most deep and less evident relational patterns. This includes forms of relating to others that seem less problematic, better adapted, or too adapted on the surface, but in turn hide the internalized sexual stigma at a high emotional cost. And finally, therapy as long as this one makes it possible to show the therapist's personal and professional changes. This is especially evident in the last process, where it is possible to observe the therapist's most recent years of training and specific studies on therapeutic work with LGBT people. Well, now I'm going to tell you, and this is the premise of this presentation, some learnings we have had doing this research and other ones for a sensitive and culturally competent approach to research and to psychotherapy. First, some main idea about internalized stigma. The first is that internalized sexual stigma is associated with negative mental health indicator. We have evidence about that, and there is a lot of evidence around the world about this. It's not that new. Second, a great challenge for therapists is discern when, how, for what purposes explore and analyze with their patient the internalized sexual stigma or its expression. And in a third place, part of the therapeutic work has to do with develop a progressive awareness of the connections between internal and external world of the patient. specifically specifying the moment when and the sources from which stigmatized feelings around the patient's sexuality originated. Many of these experiences could be subtly and gradually normalized, and that is why sometimes the link between stigmatization and symptoms are hard to establish. Multicultural competence is defined by Wallace as going beyond the mere possession of multicultural sensitivity to also attain an acceptable level of knowledge, a sufficient shift in attitude, and the production of a repertoire of behavior consistent with successfully interacting with diverse populations in multicultural settings. This means, in terms of knowledge, to make an active effort to meet the needs of a client based on individual differences. In terms of attitude, always review our beliefs and prejudices, and also look for respectful immersion in the otherness. And regarding practice, this means the production of a repertoire of psychotherapeutic practice attending the specificity of different cultural settings. Other important learning has to do with listen who knows. First, the participant as experts. From my point of view, a program of research like this must include qualitative research. We as researchers are experts in method and technique that allow the participant to communicate their experiences and transform them in knowledge that may improve clinical practice. Also, implies to provide psychological and identity-related place from which the participants can share their testimony of an experience that transforms them, helps them to grow as individuals, and or complete them in their subjectivity, eventually becoming a comforting legacy of others. And so far, in our studies, we work with a trans advisory board because as cisgender people and researchers, it has been important to recognize the impossibility of having a finished knowledge of a radically different experience, and the need to move towards the oppressed group's claim of nothing about us without us. This is a step toward this principle, but maybe not enough yet. And other learning has to do with the come and back movement from aggregation to single identity. A person has a number of identities, and a person's salient identity is the identity that comes into play in a specific situation. Someone's salient identity changes depending on the situation. So when doing research and practice, it seems important to ask which identity comes to play in the psychotherapeutic dialogue, and in what extent we are given a space to them. Also, when understanding internalized stigma, it's important to consider the experience of multiple oppressed identity within an individual, for example, gender, race, class, power position. And at the same time, focus on resilience connected to these multiple identities. Finally, it's important to not forget that therapists and researchers also have identities and reflecting about our position of power and our willing to change. And this learning of embracing diversity and complexity has to do with a virtuous way of approaching to this program of research in three ways: making zoom to different aspects related with mental health and psychotherapy in sexual identity and gender diversity, developing networks, and trying to guide our studies by the practice-oriented research. And also has to do with create research teams enriched by diversity, different genders, researchers, clinicians, undergraduate and postgraduate students, and all kinds of other science identity. Thank you. Gracias.
Thank you very, very much, Alemka, for your wonderful talk. I find it very, very interesting. We're going to open up for questions, comments, anything you might want to ask or tell Alemka about. You can do this by entering your thoughts or questions in the chat box below, or by raising your hand and speaking with us directly, whatever you find most comfortable for you. We have a raised hand, Frankie.
Hi, Alemka. Thank you so much for your talk. It was really fabulous and inspiring, I thought. And from what I've seen in research, it doesn't seem like there is a lot out there about psychotherapy with individuals in the LGBTQ community. I'm wondering if you might be able to share your slideshow from today.
Okay. Sorry, I didn't understand the last part of your...
Would you be able to share the slideshow from this afternoon's presentation?
The last slide?
The slide deck, the whole presentation, or the PowerPoint.
Okay, it's not a question right now. Yes, if not will be a problem. Happy to share the slides.
Here also, Frankie, the webinar is being recorded, and this is going to be made public for everyone. Also, Alemka, I don't know if you want to leave your mail in the chat box so people can write to you. Also, in the meanwhile, I have a personal question. I was wondering, especially when you were talking about embracing the diversity and the tell or not to tell dilemma, what would be the ideal implementation in training for psychotherapists? Should there be specific courses? Should it be worked in general undergraduate modules? What are your thoughts on this matter?
Yes, I think that there is two aspects of this idea of embracing diversity. One aspect has to do with, I think, with the side of the researchers. We in our team have this idea that we do academic activism. We are not LGBT activists, I don't know how to say, but following obviously the rules of research, we have a position, a political also position, and our work is inspired to provide knowledge and better conditions for people that historically have been marginalized, and all I told you in the presentation. And part of this activism had to do, academic activism had to do with this idea of embracing diversity and celebrating diversity. And this also is part of transmit this inside the practice of research. And when, for example, I teach researching, no? This is the first part of, I don't know if I answered totally the question, but, and regarding the student, the formation in psychotherapy, I think that the idea we are trying to work and the evidence we are trying to develop has to do that affirmative practice that is a kind of position in psychotherapy with LGBTQ people is not enough sometimes. Yeah. It's important. It's a very important position, but it's not enough because it's more complex than affirm the identity of the patient. Because sometimes affirm the identity of the patient without working internalized stigma, for example, it could be worse. Nevertheless, the therapist is trying to do his or her best. I don't know if I explain myself. So this is one learn. This is one aim we have when we think on a culturally and sensitive, competent psychotherapy with LGBT people. And I think that this model is a model also that would be a kind of orientation in the information for other minority groups that requires think about the specificities that has to acquire psychotherapy. I don't know if I answer your question, but
perfectly. Thank you very much. And Alemka, I think that what you were saying goes with one of the questions that we have in the chat box. We have two questions, but the last one asks, what is the most important next step in this field of research?
Well, I think that first, the step we have done so far are not finished. So I think that the next steps, I think, are the same steps first. We need more research about this. I would be very happy that the same question we are trying to respond in our research will be taken from other research teams. And first, obviously, it's not the same, but I will be happy to the other research team would do the same, you know, and happy to make networks and accumulate more evidence regarding this. There is, from our point of view, a lack of this kind of research, mainly in Latin America. So I think that this will be one step. And second steps, I think that I can imagine yet second step. We are going to specify, or maybe this is a second step, be more specific in the research of different groups within sexual and gender diversity. So there is all this work that is doing Claudio Martinez, that is here, regarding psychotherapy with trans and non-conforming, gender non-conforming people, which needs a specific view. And I've been thinking about that we have to look in deep the case of bisexual people and also women bisexual, and also I think that we should look in deep the case of lesbian women, no, because there is another identities or oppressive experience that are not the same, for example, for gay men. No? So I think this should be other next steps.
Very, very interesting. Thank you, Alemka, for your perspective. We have a lot of questions in the chat box and a lot of comments and thank yous and congratulations. We also have a question from Heidi, who asks if you have any thoughts for therapists who are LGBTQ plus working with LGBTQ plus patients.
Yes, I don't know if I have some statements. I really have, and we research team have some question, because in this qualitative research we are conducting, it's not closed. When we prepare a presentation for Denver for the last SPR meeting, we realized that we have been assuming that therapists have no sex, no sexual identity. So all the time we were thinking about LGBT patients and therapists, and we haven't been asking to the therapists about their own sexuality, their own sexual identity, and the impact or the way it's part of the therapeutic interaction. So we have a lot of questions in this regard. We are a little ashamed for not thinking before about this, and other studies have shown there is a discussion between the idea of match, that maybe a patient, I don't know, lesbian patient should have lesbian therapist. There is a discussion about that, but we have not data yet about this, and also it seems that the disclosure of therapists about their sexual orientation seems to be positive in this case, and not only with LGBT patients, also with heterosexual patients, because sometimes appears that not disclosure could be a kind of concealment of the sexual orientation, and would be difficult to establish a good working alliance. But these are some ideas. We have also to work more about this. Thank you, Heidi, for this question.
Thank you, Alemka. Here, we also have an report from Ludmila. I'm going to read a little bit of what she wrote, because I find it's very interesting. She says she works with human reproduction, and patients arrive looking for psychotherapists that don't make an issue about it, as you said. But sometimes they talk about the discrimination they suffer from different personnel at fertility clinics, or wonder how to talk about at future schools. And thanks for your work. Thank you, Ludmila, also.
So I am reading again because it's long. They don't talk about the discrimination. That's so long. Okay. Yes, I don't know. I think that this dilemma, you know, to tell or not to tell, to what is an issue, what is not an issue, maybe is in the core of the way in which internalized stigma, internalized stigmatization, maybe is part, or have been part, or sometimes is part of a kind of internalized sexual stigma, or internalized different stigma in the psychotherapy, you know. And I think that this kind of, because I have what I have read in the interviews, I don't know, it's the core of the working with these people that have lived oppression, discrimination, and what therapists maybe should learn is the best way to talk about this. I think the therapy is the space to talk about the difficult issues, you know? And these are the most, I think, difficult issues. There are other issues, but in the case of patients, clients that live oppression, live discrimination, stigmatization, and so on.
Thank you, Alemka. Do we have any more questions, comments, thoughts? In the meanwhile, I would like to let everyone know that I've pasted in the chat box the links to the Society for Psychotherapy's Research official webpage and Facebook page, where we will be sharing the recording for this webinar. And you will also be able to find all previous webinars and the ones that are coming up next also. So be sure to follow these pages.
If there are not more questions, I also want to say that I appreciate this space and tell you all that it would be fantastic if this presentation have the result of you knowing me, and we will be very happy to receive asking of contact and make networks and new ideas of research, because there is so much to do regarding these topics and other clients, patients, persons that are stigmatized. You know, not only LGBTQ people in our country, for example, migrant and original people. I don't know how to say in English, and it would be very good for us to open a conversation, you know, and this.
Alemka, I would like to add to what you're saying. I find that it is most interesting and necessary, your perspective. You were talking about what is an issue and what is not an issue. And I find this is wonderful, not just for LGBT plus communities, but also for all general minorities. And the prejudice that the therapist or the clinician has, and what they think might be the problem, and where we should be opening the door to listening to what the patient has to bring and what their story really is. So I also think that you've done a wonderful job of bridging two areas that tend to not be that connected, and they should be more connected, which is psychotherapy research and psychotherapy. You showed us a great example of how research can nurture and give to clinicians in their day-to-day work. So thank you very much for your time, for your presentation, for your knowledge. And I would also like to thank everyone in the audience for all your questions, for your attentions, for joining on another one of our events. I would also like to invite everyone, as I said before, to follow us on our social media. And the next webinar is going to be hosted by John Norcross. He is going to be speaking about psychotherapy relationships that work, which is going to be in the first days of November. So thank you all very much once again for joining. Alemka, thank you very much for your time, and I'll hope to see every one of you again. Thank you.
Thank you very much. Thank you to be here.